Alright, let's talk about chronic kidney disease, aka renal failure eventually. Renal failure does not mean, it could be acute. Acute renal failure means AKI. It could be happening to someone that just like randomly. It doesn't necessarily mean you're getting CKD. It could have the same symptoms as CKD, but it doesn't technically mean that it's CKD. Basically, chronic kidney disease is when you lose a majority of your nephrons but still have functional nephrons. You only have about 25% of them left over is when you get CKD. It's a silent disease because you don't have symptoms until disease is quite advanced. So the disease progression has to be monitored using stages, and an AKI would actually exacerbate kidney disease. So because you only need half a kidney to filter blood and eliminate waste, you only really see the problems happening when 3/4 of them are already kind of effed up. So yeah, it's a slow progression. Most people that are at risk are, the highest people at risk are hypertensive people, diabetes, and people that have kidney stones or a lot of kidney infections or UTIs. It's basically saying like in the end, if you end stage renal failure, ESRF or ESRD, is when you have no functional nephrons left. You need to check the GFR, creatinine, BUN, and see if there's potassium problems. You can't technically cure it, you gotta manage it with HD. You have a gradual loss of kidney function, impairs homeostasis, repeated injury to kidney loss of nephrons. So the kidney functions, so reabsorbs the good stuff and gets rid of the bad stuff. So filters blood via the glomerular filtration rate. We'll talk about in a sec. This is the rate at which blood is filtered, measures kidney function to eliminate excess fluid, over 1 liters of fluid per minute. And also waste products are eliminated from the blood, especially urea. Must be eliminated to prevent toxic buildup, and you get azotemia. You have nitrogen and urea buildup, like a lot. We usually get out 1.5 liters per day in urine. Kidneys absorb what you need and excrete the rest, and urine's made regardless of what's going on in your body. Even if you're like super dehydrated, just die on an island by yourself, you literally always will pee. It's only waterable waste products, so urea, creatinine, metabolic waste in the urine. Electrolytes, sodium, potassium, all these electrolytes used to control the fluids amounts in the body. Food and meds change the color of the urine, and water as well. Basically, if you have low GFR, basically shows high creatinine, or yeah. So anyways, normal GFR is 60 to 120. Anything below 60 is kidney disease and damage. So anything at 60 or below is a problem. Anything below 15 is problem. Like it's literally the end, like for the kidney. 60 is the range for kidneys and hearts. Creatinine shows with GFR if kidneys are working well. So excretion of creatinine is identical to GFR rate. So basically, if you have a higher GFR and you have low creatinine, low urea, that means your kidneys functioning well. But if you have low GFR, which is basically what we're talking about, you have urea that's high, you have creatinine that's high, that means kidney function is not great. Creatinine is basically a waste product of metabolism. It's not meant to be absorbed, and it's supposed to be secreted by the kidneys, but not in a place where it's supposed to be so much. High amount of creatinine shows that kidneys are not filtering well. Urea is basically a byproduct of ammonia breakdown and release in urine. Increased urea in blood means kidneys not working well. You have to have a low protein diet even then for both liver and for kidneys. It's water soluble, so it could, I guess, yeah, potentially caught across a blood-brain barrier. Kidneys also excrete hydrogen and reabsorb by carbs, so if you can't do it, if you're not functioning well, so you've got metabolic acidosis going on here, it activates vitamin D, so releases the hormone to activate vitamin D in the liver. So calcium can be absorbed for bone health, so it also makes erythropoietin, EPO, and tells bone marrow and the bones to make more RBCs. Basically, when there's low oxygen in the kidneys, they sense this. and then it increases EPO to make more RBCs, and the body can get more oxygen this way. It also maintains electrolyte balance. So if you have low perfusion in kidneys and then you get vasoconstriction, if that doesn't work, then RAS is activated. ADH is released from the brain. When blood pressure is low, then returns H2O blood, retains basically blood to increase blood pressure. ANP and BNP released from the heart and the brain to help diuresis. So atrial natriuretic peptide, brain natriuretic peptide, but it's also due to the stretch of the heart. Maintains electrolyte balance, so decreased fluid, decreased calcium, sodium, protein intake. Sodium is increased due to retention, increased fluid volume. ACE inhibitors are helped for this. ARBs diet intake diuretics, specifically spironolactone is better, but you have to be careful of hyperkalemia. Furosemide is not really good for the kidneys at all. High doses can eventually exacerbate kidney failure, causing an AKI because it's really harsh on the kidneys. So try to use spironolactone as much as you can. Also, there's a lot of fluid shifts problems, electrolyte shifts with this, so it's a lot of dehydration. And then if you get dehydrated, it can increase the low blood flow to the kidney and releases renin again, causing more increase of volume and not good. So basically, what it's meant to be doing to help the kidneys is actually going to F up the kidneys even more. Potassium increase causing arrhythmias, blocks, bradycardia, PT wave. Hyperactive nerves, you need to have lower potassium, and to do that you can do dialysis. Calcium is lower due to kidney not releasing active vitamin D hormone, so lowers calcium absorption. Low calcium causes increased PDH. Calcium and phosphorus pull from the bone, so you have to give a vitamin D supplement. Cholecalciferol. There's an increased risk of falls this way. Phosphate is increased because kidney not able to filter, and due to low calcium levels triggering PTH. Calcium and phosphorus pull from bone, give phosphate binders to decrease phosphate and increase calcium. Phosphate needed to make ATP if phosphorus is low due to increased urine output or dialysis. Phosphate can be low due to having too much urine output. Magnesium is high, important for muscle and nerve function, helps transport calcium into heart cells, works with, so if you have a kidney problem, you're going to have a heart problem, and you will eventually have a lung problem as well. A lung problem, and you also have a kidney problem. Ectopic beats in AFib and sinus rhythm. So basically, bleeding outside of the tissue. Chronic kidney disease, let's say sodium water balance, so hypertension, increased vascular volume, heart failure. So chronic kidney disease can exacerbate heart failure a lot. Potassium balance, hyperkalemia, abnormal peak T wave, increased vascular edema, third spacing. Elimination of autogenous waste leads to uremia, pericarditis, and then uremia, having a high amount of it, causes coagulopathies. You'll have bleeding, as well as on top of that, if you have a liver situation as well, then you have even more intense bleeding because you're not, because you have thrombocytopenia. Yeah, acid-base balance, lethal buffering. It'll cause more breathing, activation of vitamin D, hypocalcemia, phosphate elimination, increased phosphate due to bones being pulled for calcium, hyperparathyroidism, so increased PTH pulls calcium from bones. You'll have sexual dysfunction, neurological manifestations, GI manifestations, uremic frost, white blood cells don't work well because of I guess in general. Leukopenia is specifically for splenomegaly. Alright. For diabetes, you gotta be careful because insulin resistance from CKD Don't take, therefore oral meds, change to insulin, because kidneys metabolize insulin usually, and if you can't clear it, then you have a high risk of hypoglycemia. Hypertension and CKD, kind of talked about that. It kind of like is a negative feedback loop, so give ACE inhibitors to reduce blood pressure, maintain GFR. If not working, then use angio receptor blockers. Anemia, low hemoglobin, obviously erythropoietin, EPO. Stroke. Let's talk a little bit about this. So nephron, this is a nephron. Afferent glomerular filtration rate, afferent. Glomerular hydrostatic pressure. Hydrostatic pressure from the capsular space, and then colloid osmotic pressure as well. So basically they fight against each other, and they have the vasa recta to do the counter-current exchange. You have intrinsic mechanism, increase or decrease the afferent arterial. Extrinsic is like increasing the blood pressure through the sympathetic nervous system, obviously. Basically it stimulates afferent to contract, and then RAS as well, and then harmonical control to decrease blood pressure if it's too much, so atrial natriuretic peptide for diuresis. Renal autorelegation, so PCT, you'll see the reabsorption of sodium, chloride, bicarb, potassium, water, glucose back into the blood. Hydrogen acid secreted from blood back into there. If high pH, blood is increases pH if blood is acidic. Okay, there's podocytes here. Only our RBCs cannot pass. Plasma proteins cannot pass, and only fluid. So if your kidney is not doing all this shit, it's not filtrating properly, and the nephrons are not working well, you'll see blood in the urine. You'll see plasma, proteins that are big. Yep. No large proteins. Amino acids. SNS stimulates to constrict more blood flow to kidney. Is low due to exercise or fight or flight. So rest and digest. PNS activation here. Loop Henle, where furosemide works to counteract reabsorption of water back into the loop. So within ascending, hydrogen reabsorbed back into, basically water reabsorbed back into the blood. Solute concentration increases as it goes up, and you also see like sodium goes up as well. But this situation basically pulls in water, pulls in more sodium, magnesium reabsorbed back into the blood. Distal convoluted tubule. Basically, in this situation, CKD, you can't excrete hydrogen, you can't reabsorb bicarb, so you have metabolic acidosis. Basically, you're supposed to meant to reabsorb water back into the blood to increase blood pressure if you need to here. Secretion, aldosterone, antidiuretic, so you don't want to pee. So it secretes that in here. Potassium, hydrogen secreted from blood, acidic, and dumped in the end. Sodium, chloride, magnesium, bicarbonate, calcium reabsorbed back into the blood. But if bicarb not able to be absorbed and hydrogen not be able to, problem. Sodium reabsorbed, angiotensin, aldosterone. Drugs, organic waste from food, beets, and blah 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 dumped. ADH pulls out water. so it doesn't pee. More retention. Reabsorption saves the good stuff. Segregation gets rid of the bad stuff. Creatinine goes to the ureter. GFR is first. Tubular reabsorption. Tubular secretion. So yeah, let's look a little bit here. Anything that's a prerenal problem here can cause azotemia. So a drop in blood pressure, impaired blood flow to kidneys due to hypertension, diabetes, CHF, hypovolemia, so hypertension, low blood flow to the kidney, or increased damage of pressure, or diabetes and CHF damage, or diabetes damages vasculature, the basal membrane, becomes smaller, stiffer, harder. All of these prerenal, intrarenal, postrenal can all lead to CKD. Yeah, so intrarenal is like basically direct damage to the kidneys from toxins, drugs, infection in the blood, and lower blood supply. So hypertension can do that. Diabetes affects inside of it too, because the stiffening. Azotemia, trauma, alcohol, nephrotoxic drugs, furosemide and Lasix, like very harsh on the kidneys. Yeah. Can cause dehydration, can also cause other problems. Pyelonephritis, kidney infected due to a sudden UTI, glomerulonephritis, antibodies attacking glomerulus, autoimmune, lupus. Can also be autoimmune if anything. Polycystic kidney disease is genetic, so stir on the kidney compressor doesn't kill them. And then the post-renal situation, you'll see obstruction of urine flow due to BPH, kidney stone, splatter, tumor, ureter, repeat UTIs, Foley, not draining properly, causing urine to back up into kidneys, nephrons blow up. It's avoidable. Urine backs up and injures kidneys. Edema. You'll notice that edema with kidneys, you're seeing the face and the eyes, and the lungs. Once it's backed up, in the hands, and the feet and the ankles. But heart failure, you'll see JVD, you'll see pulmonary from left-sided, you'll see the feet. From liver, it's mostly the ascites and their feet. And then this person that has a body situation, you'll see cosmal respiratory reasons because of metabolic acidosis. You'll see urinary frost when it's really bad. You'll see confusion due to nitrogen and waste buildup. Azotemia, you'll see them tired because they're anemic. Hemoglobin, RBCs, erythropoietins not being produced. You'll see puffy eyes because of edema. You see metallic taste in urea, so oral care is very important. Pruritus secondary to urea, and also ammonia and bilirubin. Mostly, yeah, a lot of shit going on if you have both. Low calcium because vitamin D not released to be activated by liver, so a lot of bone problems. Urea buildup in the pleural space here even. You'll see edema in the hands and the feet and the face. Bone pain due to a lot of PTH pulling out calcium and phosphorus from bone. Perfusion, you have cool perfusion molecules being made. You're going to see hella urine in stage 3, but not that much in stage 5. You see muscle cramps because of low magnesium, low calcium. In your blood test, you'll see GFR is low, urine nitrogen is high, and creatinine is high. Kidney panel. But urinalysis, you'll see glucose, protein, red blood cells, and white blood cells. All shouldn't be there. Not supposed to be in P because they're always supposed to be lower than GFR. I'm gonna say the consequences, but not in coded detail. Consequences of CKD: azotemia, metabolic acidosis, hyperparathyroidism, bone turnover, anemia because there's not enough production of EPO by the kidneys to make red blood cells by the bone marrow, hypertension, tachycardia from anemia, and metabolic acidosis, heart failure, kidneys not able to excrete water and sodium, so there's a volume overload. You'll see JVD pounding pulses. You'll see edema, metabolic acidosis, especially in stage 4, stage 5, mineral bone disorder, stage 4, stage 5. Okay, last little part. Alright, now you will see stages of chronic kidney disease. Stages are based on GFR. The donor GFR is 120 mils per minute, 60 to 120. Stage 1 is more than or equal to 90. You have a risk of heart disease. Basically, you have IV contrast is not good for kidneys. Therefore, important to check hydration. Can trigger status to flush out from system and minimize harm. Increased nitrogen in urea can cause bleeding due to suppressing platelet formation and function. This can also cause thrombocytopenia. So when you're at the stage 1, it's like when you have 75 of your nephrons are lost, so half of it, basically you're at the mark of like 25% of your kidney function left. You get hypertrophy and hyperperfusion. Signs and symptoms. No signs and symptoms really. You have normal bun, creatinine, the protein in the urea. There's glucose potentially, or every cell's white blood cells. Stage 2, 3, and 4. You have renal insufficiency. You have more than 75% of your nephrons lost, maybe, and you can't regulate urine. You'll have a lot of peeing, a lot of sleepy peeing too. Increased bun, increased creatinine, low phosphate, low magnesium. This is when your electrolytes start shifting. Nephrons are able to resorb sodium. That's because of dilutional. Hard to make ATP in urine output. End stage is less than 15. You have increased bun, uremia, new for nephrons want to shift for blood, azotemia, oliguria. You can't make enough urine. You have 10 mils of urine per hour because nephrons don't work. And then you need dialysis. Yep, you need to do a lot of lifestyle changes, restrict protein, potassium, phosphate, sodium in the first stage, bone health, avoid malnutrition, psychological support, a lot of these conservative treatments, basically withdrawal of dialysis, uremia. Urea levels start to increase. Uremia causes immunocompromise. Urea causes coagulopathy, so you have a higher risk for bleeding because EPO is not being made. And also uremia causes platelet dysfunction. Okay, increased risk of infections, pneumonia, flu, Hep B. You have urea levels start to hella go up. Nausea, vomiting, diarrhea, pruritus, constipation, weight loss gain, weight fluid overload, depleted. GI skin disorders, anorexia, nausea, vomiting, hiccups, metallic taste, constipation, GI bleeds, urinary pruritus, so the person can bleed. They also only helps, hyperkalemia, a lot of potassium. May need to discontinue meds, change dietary with glucose, insulin, but dialysis is best treatment. Let's go to dialysis. Also, you gotta be careful what GFR is when you're doing a protocol. If it's less than a certain amount, if it's less than 30, then you can't use a protocol. You might have to use something else. Treatment for, okay, so hemodialysis is removing waste products from the side of the body, acidosis, electrolyte balance. AV fistula is needed for this, needs to be inserted 6 months before, takes 6 weeks to mature, monitor infection, breed, labs, hypokalemic risk. Hypokalemia because of all the fluid loss. Peritoneal dialysis removes waste products using peritoneal membrane. Monitor labs and hyperglycemia. Better hemodynamic control. You have acute hypokalemia because it's quick. Kidney transplant, dialysis, dialysis, basically withdrawal, palliative.